All of you, on behalf of the Indian Academy of Cerebral Palsy, the master class series. Today we have with us Dr. Dhiren Ganjwala to speak all of you about this examination assessment, which is a very, very important area. Actually, when we started studying with cerebral palsy long ago, we have not understood anything. But now we are in a stage to know maximum about the cerebral palsy, all the aspect of what is the problem, how to solve it. Many things has come up in last 10, 15 years. Many people have worked throughout the world over it. And from our country, those who are also very advanced knowledge in this field, Dr. Dhiren Ganjwala ji among them. He is a great teacher. He explains everything very correctly and with all types of pictures and everything. He has a good understanding. Many things we have learned from him. He himself also creates his own this PPT with all the good diagrams. And Dr. Dhiren Ganjwala, to speak about Dr. Dhiren Ganjwala, he has a wide experience in pediatric orthopedics and cerebral palsy. He has worked in many places in the world, basic qualification in India. Then he has got trained in Switzerland, USA, and many places also. He has worked in Manipal, observed everything. But one thing I have learned from him, where he is very keen observer. He's always he is very much interested. Always Dhiren Bhai is a strict academician. I can say he's a strict academician. We always, I have a respect from him personally, and he's a good speaker, not only in the medical field, also many things in many fields, also leadership qualities. He has got many series of lectures. So no doubt he is a good speaker in this occasion today. And he was our past president of the Pediatric Orthopedic Society of India. He has published many papers in, and almost always a faculty since last 15, 20 years in all POSICON, also in IOCON, many orthopedic conferences, active member in Gujarat Orthopedics, Indian Orthopedics, as well as Pediatric Orthopedic Society of India. First, we he had once upon a time, long back, in your polio hospital, and also he was the organizer of the Indian Academy of Cerebral Palsy conference also. We had attended at Ahmedabad. So many things has to introduce to him. So many basic thing is he's a good human being. He is a good teacher, which is essential for us to get the knowledge. Now that knowledge transfer is very important, and he has understood the subject perfectly, which he can also explain you very simplifying ways to understand. He has also experience teaching physiotherapy students also in Ahmedabad and Gujarat and many colleges. So I think today I welcome you, sir, for this master class series program of the Indian Academy of Cerebral Palsy. And thank you very much for accepting our invitation and to teach our members, participants, or many people are interested has been to learn from you today. So with this introduction, I invite you to deliver the lecture on how to assess a child with with a cerebral palsy. Thank you, sir.
Yeah, thank you.
Thank you, President, sir.
Yeah, I would just start sharing my screen. Just a minute, slideshow. Yeah, can you see the slides? Yeah, okay, perfect. Shaktidas introduced me so well that it looks like it's my urology going on. But thank you very much, Shaktidas. You are kind, and like the first of all, the support, love, the confidence, the Indian Academy of Cerebral Palsy, the whole team has put on me. I really appreciate that, and that's really the nice of the leadership at Indian Academy of Cerebral Palsy. In this presentation, I'm going to share my views on how to assess the children with cerebral palsy. And let me tell you frankly, over the years, I have developed something in my mind. And whenever I see a child with cerebral palsy, I try to assess in a different way. And that method I will try to explain to you. So there are 2 points which we are going to discuss. In the first few minutes, I'm going to tell you why assessment is important. And the second, the most important thing, how to carry out assessment, that will be the second part of the session, or probably that would be the longer part of the lecture. So let's come to the first point. Why is assessment important? We all know that in cerebral palsy, particularly our aim of treatment is to improve walking. Almost 60 to 70% of the children are able to walk. And in that, those patients, our major aim is to improve walking. I consider a person with cerebral palsy walking like a person who is walking on a rope. There is a very narrow safety margin. And we all know that if this gentleman makes some mistake, then probably he will fall a lot of in a depth, and that would be difficult for him. So similarly, we need to remember that these children or adult with cerebral palsy have a very narrow safety margin. And if our decision is not proper, particularly the decision regarding the surgical treatment is not proper, then they may lose their walking ability. So it's a big responsibility of everyone who is involved in the management that whatever we can achieve, we need to improve. And for that, we really need to make particular attention to the management. It's rightly said that good decision is more important than incision. This is a very famous pediatric orthopedic surgeon from Toronto, Canada. He said that, please remember that it's very easy to operate a child, but when to operate, where to operate, these decisions are very important. And we all understand now that for good decision, one needs a maximum amount of information. Without adequate information, we cannot make a proper judgment. We cannot make a good decision. So it's very important that we try to gather as much information as possible.
मेरा चश्मा दे दो.
Coming to the source of information, we have various ways from where we can gather the information. The first is the history. History plays a very important role in gathering the information. The second source of information is clinical examination, which is going to be the focus for today's lecture. The third thing is like we need to observe the walking of the child. So gait assessment is very important. We are trying to improve walking, and for that, it's very important that we assess the child while the child is walking. The fourth component is imaging. And the last one is the computerized gait analysis or the 3D gait analysis. Now, these are the 5 sources of information. Most of the centers in India are not having the 5th one. And so we need to understand how, with the help of these 4, we are able to make a good judgment. So clinical examination is one of the 4 sources of information, and we are going to focus on that part now. So now we are coming to the second question, which is very important, and that question is how to carry out musculoskeletal assessment. The first thing, whenever we look at the child, we need to decide what is the GMFCS level of a child, the gross motor function classification scale. What is a level? There are 5 levels, and the first 3, the better one, they are called the ambulatory child. and the fourth and the fifth are considered as a non-ambulator. So we need to remember that the surgery are more effective in level 1, 2, and 3. And level 4, yes, we may carry out the surgeries, but we need to explain to the family that the results are not that great. In my initial year of practice, when this concept was not available, I was always baffling that if I carry out a same surgery in the similar looking children, in some of them I am getting result and in some I'm not getting result. In 2000, when this concept was introduced by the Canadian team, I realized that it's the GMFCS level is making the difference. Before that, I used to blame the parents or the family that you are not paying adequate attention for the physiotherapy, and that is why we are not getting the result. Later on, I realized that it's not the parents who are responsible, but it's a GMFCS level which is more important. So the most important or the first thing we need to understand the GMFCS level of a child. Then we need to understand a second thing. Whenever we look at a child, there are two types of factors which are responsible for motor impairment. When I say motor impairment, we are trying to say the standing, walking, running. So those are the motor activities and which are the factors which are responsible for motor impairments. There are two broad categories. The first is related with the brain, or we will call it a neural factors. And the second is related with the bones, muscles, joints, and we call it a musculoskeletal factors. So these two types of factors combined together makes the abnormal walking in a child. And we need to understand both of them. So first of all, let us see what are the neural components. These are the CNS components or the primary component. The factors are, they have a tone abnormality. Most of them have a spasticity, but some children have even hypotonia also. So tone abnormality is the first thing. The second one is like very important is like they have an inadequate balance. They are not able to maintain good balance. And because of that, they need a assistive supporting device. The third factor is the selective motor control is inadequate. The fourth is the sensory issues. The information from the periphery, various organs like eyes, skin, joints is not reaching to the brain. And these information are very important for maintaining the balance. And when these information are not received properly, then the brain is not able to process the information and is not able to manage the balance and the other motor issues. And the weakness is the fifth neurological factors. Most of the time, we try to provide or offer physiotherapy for these factors. And yes, physiotherapy is effective in improving them. But still, I feel that we still need to understand more. We need to discover new concept so that we can do something great for these neurological factors. The second thing which is very important for physiotherapy and orthopedic surgeon, that is the understanding of the musculoskeletal factors. So what are the musculoskeletal factors? For the sake of simple understanding, I divide them into four categories. The first one is like the muscles are short. The second one is the some muscles are long. The third is they have a joint problem. The some muscles are not, some joints are not proper. And the fifth one is they have a bone problems, particularly at the femur or at the tibia level. So let us see one by one. But we need to remember that orthopedic surgery works well mainly for the musculoskeletal impairments. It is not very effective for the neural component or the primary problems. So here is a very important concept. Are two similar looking children having a motor impairment? Let's say that first patient has a neural component, a major component, and the musculoskeletal component, the one in a blue, is a smaller one. In the second patient, there is a slightly different thing. The neural component is less and the musculoskeletal component is more. So now the question which we need to ask, who is going to get a better result? Both of them can be improved by orthopedic surgery. But the second child, where the musculoskeletal component is bigger, that child is likely to get better result with surgery. Now we are coming mainly to the evaluation of the musculoskeletal factors. As we saw, there are 4 factors: the short muscles, long muscles, bone problem, and the joint problems. And in this lecture, we are going to focus on the first 2, that is how to assess short muscles and how to assess long muscles. But please don't go with the idea that the remaining 2, that's the bone and the joint, are not important. They are equally important. And when we offer a treatment, we need to take care of all the 4. Okay, so the first point, clinical examination of short muscles. We need to understand that muscles become short. And the question is, why do they become short? They become short because of the spasticity. So spasticity leads to a contracture over a period of time. To understand this concept, let me show you a picture. We are looking from a lateral side. We have a distal femur, the leg, and the foot. On the back, we have a muscle, which is a calf muscle. The green one is a muscular component, and the one in a yellow is a tendinous component. Now, this child, suppose he's a 2-year-old child. With growth, in next few years, the child is going to grow. And what will happen? The bone will elongate, will increase in the length. And at the same time, the muscle will also elongate proportionate to the bone increase in the length. So both muscles and the bone, they grow equally. And because of that, the foot is in a normal position. In cerebral palsy, the bone continue to grow adequately, but because of spasticity, the muscles, they don't grow. And the one which is shown in red is a spastic muscles. And you can see that compared to a normal child, the muscle of the spastic children remain short. The tendons are relatively longer compared to the normal child. So you can see that the ratio of length of the muscle to tendon is disturbed in cerebral palsy, and that results into a equinus deformity, or the foot remain in plantar flexion. So this is the primary problem in cerebral palsy. Because of spasticity, the muscles, they don't grow adequately. At this stage, we have something to offer, but still we are not able to solve this problem completely. And then we need to go for a surgical treatment. In addition to spasticity, there are few other factors which are also responsible. The other factors are the limited activities. These children are walking much less compared to a normal child. When normal child is walking, the joints are moving, and that's provide a stretch to the muscle. And that stretch is responsible for the muscles to elongate. So that stretch provides stimulation to the muscle to grow. Now, because a child with a cerebral palsy has a limited activity, limited standing, limited walking, the muscles are not stretched adequately. And because of that, they remain short. The third thing is because these children are in a seated position for a long period. And when we are sitting, our knees are flexed. And so hamstrings remain in a shortened position. And similarly, the foot remains in a plantar flexion. So again, both sitting leads to a shortening of calf and hamstrings. So these 3 factors makes the muscle short. So the message is, in children with cerebral palsy, muscles fail to elongate during growth period. Now we need to remember that muscle shortening takes place gradually. It's not a one-day phenomena like, say, Up to 4 years, the muscles are fine and then it becomes short. It's a gradual process. And whenever we look at a child, whenever we examine the muscle, we need to ask a question: how much is a component of spasticity and how much component is of a contracture? This is a very important question for the decision making and for deciding the proper treatment. So to explain this concept, I will slightly go in detail. And the first thing is, like, let's look at a normal child. Normal child muscles are normal. And so we are looking at the leg and the ankle is in full plantar flexion. Now, if we apply a force from the bottom of the foot and we try to carry out dorsiflexion with Sonali, please mute yourself. So what happens, like when we apply a stretch, there is a dorsiflexion force and the foot will go into a full dorsiflexion. Let's say that the range is 30-degree plantar flexion to 20-degree dorsiflexion. That's the normal range. Now, instead of a rapid stretch, we provide a slow stretch, means we constantly apply a stretch. So that's a slow or a sustained stretch. Again, in a normal case, the ankle will dorsiflex to the full range, the 30-degree plantar flexion to 20-degree dorsiflexion. That's the normal range. Now, if we look at this as a picture, if this is a rapid stretch, the blue is a rapid stretch, you can see that it's a 30-degree plantar flexion to 20-degree dorsiflexion. Whether it's a rapid stretch or a slow stretch, it's same in a normal child. Now, on the other hand, what happens in a spastic children? When we say that spasticity, we understand that the definition of spasticity is it's a velocity-dependent stretch reflex. Means when we apply a rapid stretch or a fast stretch, the muscle will not elongate properly, but there will be a catch. So that's the definition of spasticity. On the other hand, if we apply a slow or a continuous stretch, there will be no catch. Now, what happens during walking? There is a sudden stretch of the muscles, and because of that, there is a catch, and that restricts the movement. While if you examine, and at that point, if we apply a slow or a sustained stretch, there will be no catch. This is a very important thing. So now let's look at this and apply this in a patient. So rapid stretch is applied first, followed by, once we get a catch, after that we applied a sustained stretch. So let's see what happens in cerebral palsy. The starting position is 30-degree of plantar flexion. From that, we carried out a rapid stretch and we get a catch at a neutral position or a 0-degree of plantar flexion. Now, beyond that, if we apply a slow or a continuous or a sustained stretch, we will be able to get a further dorsiflexion. And in the initial years, this dorsiflexion is full. So let's see this as a picture. The first one is a blue component and the stop is called R1, the response 1. And after that, there is a pink zone and in which we get a further degree of dorsiflexion with a slow or a sustained stretch. So that's the initial years. After next few years, again, we start with the plantar flexion and we get the first catch now at 10-degree of plantar flexion. Previously, it was 0-degree, but now it's a 10-degree plantar flexion. And beyond that, if we go further with a slow sustained stretch, we get up to a 10-degree of dorsiflexion. Previously, it was 20-degree of dorsiflexion. Now we are losing the last 10-degree of dorsiflexion. If we show this in a picture, the initial one, R1, is a blue zone. That's a catch. With a slow or sustained stretch, we go up to R2, beyond which the dorsiflexion is not possible. The one which is shown in a gray zone is the muscle has become short, and because of that, we have lost a dorsiflexion. Again, after next few years, let's see what happened. The first catch is now at 10-degree dorsiflexion, and on a slow sustained stretch, we get a further dorsiflexion up to neutral position. And now beyond that, it's not possible. So if we look at this, this is how the things has changed. The slow sustained contracture component has become less, and the gray zone, that's a loss of range of motion, is becoming bigger and bigger. So this is what happens over a period of time, and why this is important. The range of motion up to R1, the first catch, is called the functional movement. R1 to R2 is called the component of spasticity. And from R2 to terminal range is the component of the muscle contracture. And now if you understand, the spasticity is best dealt with botulinum, and the contracture is best dealt with surgery. So this type of assessment is very important. Whether to go for botulinum or surgery, that depends. Like when there is a large component of spasticity, we go for botulinum. In this situation, you can see that the component of spasticity has become less, and now there is a component of muscle contracture. But if you look at this, here you can see that now the spasticity component, one in a pink, is less, but the one with the arrow is a loss of range of motion. That component is because of the contracture, and that has become larger. So in the third situation, we need to go for surgery, while on the first two, the botulinum may have effect. So now coming to the next question, which muscles become short? In cerebral palsy, there are 5 muscles which are becoming short. The first is gastrocolius, the second are hamstrings, the third is adductors, the fourth is rectus, and the fifth is hip flexors, or that the iliopsoas. Now there is a characteristics of these muscles. All these muscles are biarticular muscles, means they are crossing 2 joints. So biarticular muscles are more likely to be affected in cerebral palsy. We don't know the reason why, but this is the fact which we have seen all throughout the years, that biarticular muscles are affected more. So let's understand how we assess them. So let's see that how we assess the gastrocolius length. So when we talk of a gastrocolius, it's a combination of 2 muscles, the gastrocnemius and a soleus. The gastrocnemius crosses the 3 joint, the knee, ankle, and the subtalar joint. And on the other end, soleus covers only the ankle and the subtalar. So now it's very important that when we carry out an assessment, we first of all fix the subtalar joint in inversion so that the tendoachilles or the gastrocolius is stretched at the distal end. And then we carry out assessment with the knee extension and knee flexion. And we look at how much ankle dorsiflexion is possible. So the first thing is like we need to carry out a foot into inversion so that we stretch the calf at subtalar joint. That's the first important thing. And in this video, as we see, this is about the soleus length because knee is flexed and we are looking at the dorsiflexion. So we can look at the component of soleus. Now, once we have looked at that how much dorsiflexion is possible, gradually we extend the knee joint. And when we extend the knee joint, the gastrocnemius, which originates from above the knee joint, gets stretched. And that will reduce the amount of dorsiflexion. So now this difference between the knee extension and knee flexion tells us about the component of gastro. So this is how we differentiate the soleus and the gastroc shortening. Coming to the second muscle, which is again very common, and that's the hamstring length. There are various ways, but the one which is very popular is the popliteal angle. How we measure that? if we are trying to look at the right side of the hamstring, then the contralateral hip and knee are extended. Sorry. After that, we flex the hip and knee to the 90 degree. So at both hip and at knee, we flex to 90 degree. And then gradually we extend the knee joint. Let's see this with a picture. So the contralateral hip and knee shown in a blue color, which is away from the examiner, is straight. They are extended. The one which are assessing is the right side. And you can see that the hip and the knee are flexed. So when we flex the hip joint, the hamstrings is stretched at the proximal end. And when we flex the knee joint, the hamstring is relaxed at the distal end. Now, gradually, as shown in the arrow, we gradually extend the knee joint like this. And this will be restricted by the amount of knee extension is restricted or decided by the hamstring length. The angle formed with a vertical, as shown in the upper part of the picture, that is called the popliteal angle. So more the hamstring is short, more is the popliteal index. So this is how we look at the popliteal index. So this angle is called the popliteal index. Coming to the third group of muscle, that is the adductor's length. Again, we need to understand the anatomy in a slightly detail, that there are 4 adductors. The one is adductor longus, the second is adductor brevis, the third is adductor magnus, and the fourth is gracilis. Gracilis is on the medial side of the muscle. Some people, they consider it as a part of the hamstring or a knee flexors, and some people call it as a adductors. Now, of the 4 muscles, the first 3, that's the adductor longus, brevis, and magnus, they are monoarticular muscles, means they cross only the hip joint. While gracilis, on the other end, is a biarticular muscle. So we need to again examine with the knee extension and knee flexion. So let's see how we do it. So the first component of the assessment is the adductor assessment part 1. With the hip and knee extended, we try to abduct the hip joint. We try to widen the hip joint like this. And the angle it forms with the midline, we measure that this is what the abduction is possible. Now, the second part, we flex the knee joint. So that releases the gracilis. So if there is a component of gracilis muscle, that will be nullified with the knee flexion. And now again, we continue with the hip abduction like this. Now you can see that the knees are flexed, the gracilis is relaxed, and then we carry out abduction. And this is for the right side. And this is like the first is with the knee flexion, and the second one with the knee extension. So whatever increased abduction we achieved, that tells us about the gracilis component. Coming to the fourth muscle, that is rectus femoris. Rectus femoris is a part of the quadriceps muscle. When we say quadriceps, we understand that there are 4 muscles. The first is the vastus medialis. The second is vastus lateralis. And the third one is the rectus femoris muscle. So these basically, they form the 4 muscles, and the rectus originates from the above the hip joint, and then it crosses the knee joint. So in cerebral palsy, rectus is also affected. So the test for that is called a prone rectus test or Duncan-Alley test. So in a prone position, the knee is flexed, keeping the hip extended. So hip is extended, the knee is also extended, and from that it's flexed suddenly. And what will happen? Let's see. Now you can see that the patient is lying in a prone position. On the left side, there is a pelvis, and you can see that the green is a rectus femoris muscle, which starts at the anterior superior iliac spine and insert at the upper end of tibia as a part of the quadricep mechanism or the patellar tendon. Now, when we flex the knee joint, the rectus is stretched at the distal end, and if rectus is short, here it's shown as a normal rectus, it's of normal length, there will be no effect on the hip joint. But if rectus is short like this, the hip will flex and the pelvis will tilt. Again, I will show you. This is not starting position, and with flexion, you can see that the hip flexes. So this is called the prone rectus test positive. To understand this, like the patient is in a prone position, the knees are in an extended position, and from that, we flex the knee joint. And you can see that here, the hip is flexed and the pelvis is bit lifted. So this says that this is test positive. The rectus, prone rectus test is positive. And the last test is for the hip flexors. We all know that the test for that is a Thomas test. And in that, we flex the contralateral hip till the lordosis is obliterated. You can see that the dotted line is spine and now it is flat. At this point, how much angle the femur makes with the floor, like this, that gives us an idea about the fixed flexion deformity, or in other words, how much short the psoas is. Now, one point which we need to remember while examining this, that if we flex the hip joint, the contralateral hip too much, what will happen? That will also rotate the pelvis, and that will cause obliteration of the lordosis completely. And now spine is tilted or rotated in a reverse direction. And this will give us a false idea about the hip flexion, like this. So the message I would like to give is, like, too much flexion of the contralateral side of the hip will lead to overestimation of the hip flexion deformity or the psoas length. Now we saw about the 5 muscles, how to assess them. Now we come to the second musculoskeletal factor, that is clinical examination of long muscles. Now, before we go to the concept, let us understand what is long muscles and why they become long. Let's say that this is one bone and this is a second. The junction of that is called the joint. On one side of the joint, we have a, before that, this is how the joint moves. Now, for this movement, on the one side, we have a muscle called agonist. The muscle on the opposite side is called antagonist. Now, let's assume that when this agonist becomes short, as shown over here, what happens to antagonist? And I'm sure that you will say that the antagonist will elongate. Now, this understanding, which is very simple to understand, but the medical fraternity took almost 50 years to understand that when one side of the muscle on one side of the joint becomes short, the opposite group of muscles become long. So based on that, we know that which are the muscles likely to become short. So now we can also understand that which are the muscles likely to become long. The hip abductors are likely to become long. The quadriceps is likely to become long. The tibialis anterior, which is an ankle dorsiflexion, is likely to become long. And the gluteus medius, which is a hip extensors, is likely to become long. At present, medical community is really convinced about the quadricep thing. Few doctors, Professor Reinhard Brunner from Switzerland, he also believes strongly that the tibialis anterior also becomes long when there is a plantar flexion or equinus contracture. Regarding the other two, still the jury is not out. But for the quadricep, everyone agrees on that. So how to assess the quadriceps. The quadriceps is basically the knee extension. So let's understand the mechanism how we carry out. This is an examination table on which the patient is lying like this, the hip extended and knee flexed. Now we ask patient to carry out active extension. So with active extension, the quadriceps will shorten and that will cause knee extension. So once the patient reach at this point, we try to carry out a passive knee extension like this, passively. And let's say like knee is extended this much. So now if you see this to this, this to this, the difference is called that this is because of the long quadriceps. The quadriceps is not able to carry out the full knee extension. And this component is called extension leg. Now let's assume that this person in a supine position, when this person become upright, the quadriceps is long. Because of that, it is not able to carry out full knee extension and the knee remains flex. And this is the reason why the crouch gait develops. So this is the assessment for the long quadriceps. If we really want to go in detail, we can take a X-rays and we can identify that is there a patella alta, because many of the children have a elongated patellar tendon and that will lead to high riding patella or a patella alta. That is also suggestive of that the quadriceps is elongated. So you can see that this is how the clinical examination is carried out. Initially, patient is asked to carry out active knee extension. I will play it again. This is active, and after that, this is a passive. So the difference is telling us about the long quadriceps. So we discussed this short muscles and the long muscles assessment in detail. Because of lack of time, we are not going for the assessment of bones. That's increased femoral anteversion or increase tibial extorsion. That we are not going to understand. But it's very important that on a patient, we carry out that examination. And in addition to that, we also carry out proper assessment of the joints. The 3 joints problem which are very common in cerebral palsy, at hip, there is a flexion deformity or a hip dysplasia. The second, at knee, it's a knee fixed flexion deformity. And at the foot, there is a midfoot break or a planovalgus foot. These are the 3 components of deformity which we see largely in cerebral palsy children. And we need to assess them in the in our musculoskeletal assessment. So after clinical examination, we will have all the information. And most important thing now is we need to look at the gait of the patient. So whatever we identified abnormal in clinical examination and the gait of the patient or the gait abnormality of the patient, if they are matching, then we accept the findings of clinical examination. However, if there is a situation that clinical finding is suggesting something, say Y, and the gait abnormality is saying that it's a Z, and they are not matching, in that case, the gait abnormality is more important and we need to recheck our clinical examination findings. So the take-home message I would like to give is the clinical examination is one of the 4 important pillars of information which gives us idea. In assessment, musculoskeletal assessment, we need to decide the GMFCS level of a child. We also need to separate out how much is a neural component and how much is a musculoskeletal component. And then we need to evaluate all the 4 musculoskeletal impairment, that's a short muscles, long muscles, bone problem, and joint problems. And the last, the clinical examination should correlate with the gait abnormality. And if only it correlates, then we accept the findings of clinical examination. So with that, I stop my presentation and I will be happy to answer questions.
Any one of you have a questions to ask, sir? Hello? Sir, I think there's a spellbound lecture. They are unable to speak now.
Hello, sir. This is Amrita,
Yes.
an occupational therapist. So I just want to one question. Like in the lower extremity, you told these muscles are long or short. Similarly, in the upper extremity, there is some muscles that is short and long. So could I know that in which muscles get most likely to be short or most likely to be elongated?
Okay, good. So in upper extremity, the concept is a bit slightly different, there is also a muscle imbalance over there. And it's not the length issue, which is as clear as in the lower extremity, because in lower extremity, we have a software which can measure the length of the muscle, the computer software, which can tell us about that. In upper extremity, we don't have such software. But whenever one component of the muscle is affected, we always understand the opposite group of muscle is weak. This is very common, particularly when we talk of a thumb and when we have a thumb adduction. During surgery, it is very important that we lengthen the adduction, try to provide abduction to the thumb. So this is one example. If I give you the another example, let's say there is a pronation deformity at the forearm. We know that the pronators are short, but if we want to actually improve, then we need to lengthen the pronators. But at the same time, we need to carry out something surgically to provide active supination. So some form of tendon transfer is required to manage that imbalance. So in upper extremity, it's more of an imbalance for the power point of view, while in lower extremity, it's more of a length issue.
Thank you.
Yeah.
In the chart, there is a
Okay, that's a very good question. Yeah, the Chandrasekhar has asked a question that after surgical treatment, up to what extent the gait improves? That the first gait never becomes normal. The reason is because there are two components, neural and the musculoskeletal component. We cannot do much for a neural component. They are going to be there even after surgery. We don't have any surgery to take care of the primary problem in the brain. So gait never becomes normal. That's the first thing we need to tell to the family members. Because a lot of family members, they ask this question. To us, it looks very foolish, but for them, it's really a genuine question that after surgery, everything will become normal. So we need to explain that, yes, surgery will improve the gait, but will not make the child normal. Coming to your question, which is very relevant, I try to create a framework in my mind. How much is a component of neural and how much is a musculoskeletal component? If spasticity is less, there is no dystonia component. If child balance is good, if these factors are less, then mainly gait abnormality is because of the musculoskeletal component. The other category, which I showed in a lecture, that neural component, if it's more, then surgery will not give the good result. Will definitely improve the gait, but will not give that satisfactory result to the family members. And coming to your question about the quantum, no, the science is not yet able to quantify the gait improvement or predict the gait improvement after surgery. So these are the things which we need to do in future. Yeah, any other question?
If no questions are there, then we will thank you very much, sir, for spending your very, very valuable time and accepting our request to teach us. Thank you very much.
And just one thing, like in the beginning of the first slide, I have mentioned my WhatsApp number. I have mentioned my YouTube.
Yes, sir.
They can, and if they have a question, they can definitely ask me by WhatsApp or by email.
Sir,
Thank
we
you.
will share your email ID and WhatsApp number to all the professionals
Yes.
along with this lecture. Then they can be in touch with you if they have any question on this lecture.
Yeah. So
They
some
can
of the,
discuss.
yes, I expect the question. The reason is because some of the concepts are new. They are
Yes, sir.
not really described well in the textbook. So
Yes, sir.
yes, I anticipate few questions.
Yes, sir. Thank you, sir. Thank you very much.
Thank you.
Okay.
Thank you. Bye.